Good morning, everyone. I guess I'm already live on Facebook. Okay, it's the third. It's the third Monday of the month, right? So it's another free lecture in kinetics. Good morning, everybody. I would like to see the shout out from the group, not the group, but the comment section. So just type it in if you are coming from the Philippines or elsewhere. You can type it in or any comments, any shout out that you wanted to bring. To give a good morning to everyone. I'm here in Texas, by the way, so it's 7 o'clock in the morning. It's a cold weather outside, but keep warm, everyone. Especially there's a coming something like a winter kind of a storm or blizzard or something in some parts of the U.S. and just keep yourself warm, everyone. Okay, good morning, good morning, good morning. So like I said, it's another free lecture from Connectics College. This is brought to you by, of course, Connectics College, uh, together with IPAS, one of the review centers or review programs, and other review centers for NCLEX. Say, for example, like Aspire, and then some of the English review centers like Swoosh. At the same time, your Niners in the Philippines. So here, this is the platform for everybody's at least a help. You can give a help to everyone who's on their journey to achieve their dream in coming here in the US, primarily here in the US. Okay, so by the way, I'm Jay. I'm from IPAS. I guess this is my third, fourth time here. I cannot count it anymore, but well, few times, but this is not the last time for sure, giving you free lectures, guys. And I'm really, it's my pleasure to be with you guys and do another lecture for today. And it's going to be pneumonia. Okay? The lecture for today, we're going to discuss about pneumonia. Let's reconcile pneumonia on a clinical setting. I know you guys are working in the floors in your units and you always admit patients with pneumonia. At the same time, since we are dealing with NCLEX, dealing with this journey of your NCLEX, let's reconcile the knowledge clinically at the same time what's really going on in your NCLEX. So what are the common topics that they're going to give you or related to pneumonia. Okay? So I would like to also greet everyone Merry Christmas. It's Christmas is fast approaching. So Merry Christmas everyone. I was looking at the Christmas lights last night. So Christmas lights are bright. So that's really the meaning of Christmas, right? So Jesus is so bright for us to like really appreciate his presence to us. So that's basically Christmas. But well, we're not gonna talk about Christmas though. We're gonna talk about pneumonia today. Again, like I said, let's reconcile the clinical knowledge because it's very common in the clinical setting wherever you are. Probably you're in the Philippines or in Africa, in Middle East, or here in the U.S. We always admit patients with pneumonia, and again reconcile it with the most common things that they're gonna ask you in your NCLEX related or associated with your pneumonia. Shout out. So can you comment on the comment section so I can see it? And if you have time, and then please share it to your social media accounts, for example, Facebook, page. Share it because this is another knowledge. As much as I can, I will maximize the knowledge on a minimized time. So this is going to be an hour, but sometimes I do extend for the purpose of again knowledge. Okay. So please, Miss Bilkis, is it Miss Bilkis or Mister? Thank you for putting your comment. Thank you for coming in. Thank you for joining us here. So I guess I would begin now. Can I share my screen? I guess it's already shared. Without further ado, again, I'm Jay. I'm from IPAS. I'm from IPAS. I'm one of the educators there. In fact, I'm the lead educator. We have lots of educators and mentors. So at least to help you guys in this journey. Okay, we have a good program for you guys, and then we're not only building nurses to pass the NCLEX, but we're also building a good community for everyone. Okay, so in fact, we are really planning. It's actually, it's ongoing. We have a good plan again to promote a good community for everyone, for good nurses. We have a plan that this is my first time to tell it. That whenever somebody will pass the examination, we can generate money to at least help the needy ones, the charities and those kinds of things. So, like I said, it's a big plan of mine in IPAS, and this is about sharing what you have, succeed in life. For example, passing the NCLEX, it's about time to share as well. So in every passers that we have, we can generate money to help, the needy ones, promoting a good community, not only passing the NCLEX. It doesn't stop there. Okay, so Miss Jean from Riyadh. I'm from Riyadh as well before I came here in the US. So I had a good experience there. I was also an educator in one of the hospitals there in Riyadh. It's a good experience. So I really gained a lot from my experience in Riyadh. And I miss the Middle East life. It's a quite different life here in the US though. But as an overseas Filipino worker working in a country which is, Middle East, it really helped me a lot in adjusting to many kinds of people. I'm talking about, international, uh, multiracial people. Okay, so thank you for commenting, Miss Jean. And again, if you have your Facebook account, then you can share this little lecture of mine, and at least to help everyone also, like, learn about pneumonia. Sometimes we underestimate simple topics like this. All right, please, in NCLEX, don't underestimate any topics. All right, please do not underestimate any topics. I would like to commend one of our students, because he said when he first took the exam, he said, like, I wasn't really respecting the NCLEX. In other words, he's underestimating the NCLEX because he was really a good, he has a good passing rate in achieving his uh, national licensure exam in the Philippines. So he was underestimating NCLEX. So underestimating, like, the word that he said is like disrespecting the NCLEX, underestimating. So please, if you see this is pneumonia. Oh, this is about EKG. I'm good in EKG because I work in ICU, blah blah, etc. Please, there's so much room for knowledge about EKG. There's so much knowledge with your pneumonia or many other topics. Please do not underestimate. But because who knows, like, you will encounter the 145th question on the current NCLEX. You will encounter the 145th question, which is basically, the last question, which is make or break. If you got it wrong, and then you will fail. If you got it right and you're gonna pass the exam, that's the last question, make or break. And who knows, it's about pneumonia. And then you are just underestimating pneumonia because you said to yourself that, okay, this is just pneumonia, this is an easy topic. I got it from my licensure examination. I don't want, I don't need to study about it. Well, there you go. 145th item, talking about pneumonia. You didn't know what's the complication of pneumonia that they usually ask in NCLEX. Well, and then you didn't get it. Make or break. 145th question. We don't want the last question. We want 75 items pass on your current NCLEX. Okay? And one thing for sure also, one thing for sure that I don't want you to be scared about NGN. I know NGN is fast approaching on April next year. I don't want you to be scared in your NGN. You know what? Irregardless of what is the format of the examination, irregardless of what's the format, I would say as long as you know the concept, as long as you know what is pneumonia all about, I guess you will not have problems in answering questions because you know the concept, you understand the concept, you understood it in your nursing school or in your review program. Did you get what I mean? What I'm afraid, because they're changing it, probably not just the format is or are the trending topics, the common topics. That's what I'm afraid for. For example, they're still gonna give you pneumonia, but Who knows? They're gonna give you something about pneumonia that you did not learn in your review program or in your nursing school. All right, so that's what I'm afraid for, or I'm scared for. But in regards to format, I don't have any, I don't have any worries about it. Like I said, as long as you know the format, and you will be good. So this time around, I'm gonna start it. Pneumonia. All right, I'm gonna discuss it. And like I said, we're gonna reconcile what's really going to happen in the clinical area and as well as in NCLEX. Okay? Give me two symptoms, guys. Are you ready? Can you say yes? Can you say yes from there, from the comment section? Give me two symptoms, just two symptoms for now, for you to say, you're, for example, you're in the unit or you're in the ER, and then you see a patient having these two symptoms. Oh, okay. I will diagnose that. I'm not a doctor though, but I'm anticipating that this is or this can be pneumonia. So give me two symptoms, guys. Miss Rads, give me two symptoms. Can you give me two symptoms? If the patient comes into the hospital having these two symptoms, this might be pneumonia. And what are those two symptoms? I'm gonna give you other symptoms later on. I'm just gonna at least solicit some information from you guys. Two symptoms. I only need two symptoms for you to say that this might be pneumonia. Okay, what is this? Okay, I will have to say this is what? This is your fever and your cough. Okay, fever and cough. I'm gonna erase this. Fever and cough. Can you see my screen, huh? Productive cough and fever. Very good, Miss Jean. Elaine said fever and cough. Very good. So fever and cough. See? Sometimes it's non-productive, but most of the time it's productive cough. Okay, we have different types of conditions that is associated with your fever and cough. Okay, I'm gonna stay focused on your bacterial pneumonia. Okay, the next thing that you will anticipate is for the doctor to order some form of X-rays, chest X-ray, to determine what's really going on with this patient. Is this really pneumonia? Questionable, right? Chest X-ray. Good afternoon, Miss Ifioma from Nigeria. Like I'm always saying here, I love people from Nigeria. I have a very good friend in my unit who happens to be a Nigerian, and then they're really good people. Who else? Okay, from here, from the comment section. Okay, so question mark. So is this really pneumonia or not? Question mark. You anticipate that the doctor will order imaging, right? The most convenient imaging is chest X-ray. Okay, so they might order chest X-ray if it's positive for, actually it's positive for interstitial markings. I will incorporate here X-rays. So chest X-rays, interstitial markings. So you see the findings or the impression, in your chest X-ray. As a nurse, you don't stop from just doing the typical nursing care that you're doing, to your patient, right? So you also need to look at the chest X-ray, for example. That's part of your diagnostic examinations that are very convenient, right? Look at the impression there, and then if it says like positive interstitial markings, okay, it could be flu. All right, it could be flu. I'm talking about flu A or flu B. All right, if it's flu A or flu A is not as contagious as flu B. We had like a wave of flu probably about 2 weeks ago. You have a lot of patients with flu. All right, and most of them are like flu A. Flu B is more contagious and more severe than your flu A. All right, the good thing about it is like they have vaccines here, but I don't get my vaccines in flu. I got messed up by my my flu vaccines like 2 years ago. But anyway, so I'm not gonna discuss about the complications or the things that are associated, conditions that are associated with flu vaccines as well. Say, for instance, your Guillain-Barré syndrome. But anyway, if you have positive interstitial markings, that could be flu A or flu B. All right. So another thing is if it's, okay, the patient is getting fever and cough. However, the X-ray is negative. All right. The X-ray is negative. It could be bronchitis. All right. It could be acute bronchitis. I put it there, acute bronchitis, acute, because when you say like chronic bronchitis, that's one condition of your COPD. That's one type of your COPD wherein you can really see that there is bronchitis. It will appear in your X-ray as bronchitis. All right? It will show there it's either emphysema or bronchitis. But when you're talking about acute bronchitis or chest colds, okay, so it's negative for X-ray. And the patient is developing fever at the same time cough. Okay, it's negative for your chest X-ray. The red ones represents chest X-ray. Okay, I'm just gonna write it here. The chest X-ray is interstitial markings for flu A, flu A, flu B positive, and negative for your acute bronchitis. Let's take a look at the other condition. Okay, there's this one condition which is what we know as your necrotizing abscess, right? Necrotizing abscess. Anyone from IPAS here? Chest congestion. I'm gonna tell you other signs and symptoms later on. Okay, so necrotizing abscess. A necrotizing abscess. A necrotizing abscess comes in two X-rays. I mean, two findings in your X-rays. It could be, it could be either it will tell you positive for air fluid level. All right. But I'm telling you guys, don't focus on this one. This is kind of, more medical. I would like you to focus later on in your bacterial pneumonia because that is where, the NCLEX is gonna ask you. All right. Or it could be positive cavitary. Okay, cavitary lesions. Positive cavitary lesions. Now, if you have a positive cavitary lesions, look at the word cavity or cavitary. What comes out in your mind? If you're working on the floor, you know this. Oh, the X-ray has a positive cavitary lesions. So this could be either what? Can I take a look at your comments? Guys, if this is, if your X-ray looks like, oh, there's a cavitary lesions present. Okay, it could be tuberculosis and fungal pneumonia. Okay? It could be PTB, pulmonary tuberculosis, or fungal type of pneumonia. Okay? Or PTB or fungal type of pneumonia. All right, fungal type. This is NCLEX wise, ha? They're probably gonna ask you about the fungal type of pneumonia, which is caused by pneumocystis jirovecii. It sounds like a brand of a, of a bag or something. No, it's it's a pneumocystis jirovecii is fungal. This is commonly asked, your histoplasmosis. Your histoplasmosis is coming from bird or bats droppings, their poops, all right? Histoplasmosis. And this is common to where? Letter H, histoplasmosis. Common to Ohio. Histo, Ohio. So common here in the US, particularly in Ohio. All right? So Ohio, histoplasmosis. The other one is your coccido, coccido, coccidio, sorry. Coccidioidomycosis. My good Lord. This is hard to, to really say it. But you know what I'm saying here. This is a pretty, uncommon kind of microorganisms, but this can cause fungal pneumonia. I would write here fungal pneumonia. All right? Coccidio, coccidio, coccidioidomycosis. That is one of the fungal, microorganisms that will cause fungal pneumonia. If you have a histoplasmosis common to your Ohio, you also have a fungal infection which is common to letter C, which is California. All right? California. Okay? Histoplasmosis is from Ohio. I mean, common to Ohio. And coccidioidomycosis, I don't know how to really say it. It's from California. All right? So endemic in California. But not only that, it's also endemic in, for example, like Arizona. Somewhere in the southwest of the US. Okay? Sometimes they call it as a valley fever. All right? A valley fever because it came from one of the valleys in California. I guess it's like San Joaquin Valley. But anyway, let's not focus on that one. If ever you have cavitary lesions, it's either pulmonary tuberculosis or fungal pneumonia. Okay, or fungal pneumonia. Let's go to another type, which is what I will focus more on, which is your bacterial pneumonia. Okay, so this is your bacterial pneumonia. I'm gonna write it here. In your bacterial pneumonia, which I'm going to focus about, in your bacterial pneumonia, what do you find in your X-ray? Come on, guys. Especially if you're working in the medical surgical area, we have lots of pneumonia, guys. I'm not gonna talk about COVID. I'm not gonna talk about COVID because it's not gonna come out in your current exam, but who knows? It will also come out in your NGN. That's what I'm really scared about because there are some new topics that we are not discussing, in the current program that we have. I'm not just only talking about our program, but as well as other review centers. All right. In IPAS, we already started our NGN way before, like critical thinking, how to answer critical thinking, how to answer case studies. We already started it way back since last year. But anyway, so bacterial pneumonia, guys, chest X-ray will look like what? What does it look like in your chest X-ray? Positive what? Positive consolidation. All right? Positive consolidation. This is talking about fluids. Okay? This is talking about fluids. It's already solidifying in your from the word itself. It's already solidifying in your lungs. All right? It could be positive infiltrates. Okay? It could be positive infiltrates. Guys, I'm not saying that you need to like really be an expert in interpreting what's in X-ray. You just have to look at what's the impression there, all right? Because it's the job of or responsibility of the radiologist, right? The clinical radiologist. But I just want you to look at the impression there. If it's positive for consolidation, that is pneumonia. If it's positive for infiltrates, it's either pneumonia or CHF, right? Because CHF also is characterized by fluid buildup because you're not able to mobilize the fluids, you're not able to eliminate the fluids, excessive fluids in your body, and your heart is not working properly. It will backflow to your lungs. It will cause infiltration, right? It will cause fluids to accumulate there. That's why if you look at your X-ray, positive infiltrates. This same thing as pneumonia. Pneumonia is an inflammatory process. All right. If it's an inflammatory process, you always remember that is associated with the inflammatory mediators that is being released during the process of inflammation, right? One of them is fluids, right? Increased secretions, increase in your fluid accumulation, causing infiltrates, all right? You wanted to rule out CHF versus pneumonia. You anticipate the doctor will order what? BNP, or also known as your B-type, not your retic peptide. Okay? If your BNP is elevated, all right? If your BNP is elevated, that's CHF. Can you follow? All right? If your BNP is elevated, though it's not really a specific indicator for CHF because it might be elevated in the presence of ESRD because you're also accumulating fluids and your heart is having hard time because of congestion. All right? So this is associated with CHF, ESRD. It's not really specific though, but it's not necessarily pneumonia. It will, it's most likely CHF or other, conditions. That's how to rule out pneumonia and CHF looking at your X-ray with infiltrates. Did you get that? So that's bacterial pneumonia, guys. Okay, let's take a look at the other symptoms. The other symptoms associated with this bacteria, especially bacterial pneumonia. All right. So what are the other symptoms, guys? What are the other symptoms apart from your fever and your cough? All right. This might come out in your SATA. All right. This might come out in your SATA. Signs and symptoms. What are the other signs and symptoms? Come on. Productive cough, chest congestion. I'm gonna write here chest congestion. Okay, what else? After the signs and symptoms, I'm going to discuss about the complications. All right, of course, the NCLEX is really challenging you guys in asking prioritization questions. When you say prioritization questions, it's obvious. Who are you going to prioritize? Those signs and symptoms that will tell you that this is already a complication. They're gonna always ask you about prioritization. On my case, I had probably like 80% of them are like prioritization. because this is where we utilize our clinical judgment. If you are really a safe nurse, handling patients like this, like that, and this, you know, if you are in a regular floor, you can handle as much as 5 or 6 patients, depending on the staffing, condition of the hospital. All right. So you will handle like 5 patients with different needs, respiratory, cardiac needs. These patients are high acuity patients. If you're going to treat here, well, you have to prioritize. In line with NCSBN, well, the plan is to really create an exam which is utilizing the clinical judgment. So it's basically prioritization in the current NCS. Next thing, next year, in April, we're going to have two studies, right? NCM, we're going to have two studies. This, I like that exam. You know what? Because that is what you see in the data. I'm here, regular care, also putting something on the activity here, laboratory, analysis, analysis, fever and stuff, and the symptoms. This is pneumonia, right? This is pneumonia. And whenever you have case studies, guys, whenever you have case studies, you can really, work on with your clinical judgment. And that is a good format of examination because that is to get you ready when you come here to the US and battling with those kinds of patients. Well, you're already trained with your case studies. All right. And that's why I like that kind of examination. When I was a clinical instructor in the Philippines, particularly in Davao, so my format of examination is really case studies because I teach medical surgical and I'm a clinical instructor in ICU as well because that's my experience before. So I was privileged to teach medical surgical, especially critical care, to students who are like fourth year students before they graduate. So my usual thing is case studies. All right. So well, let's focus on this one. Chest congestion. Sorry guys, too many stories. Chest congestion. What else? The audio is not clear. So just check on your end. Do we have any problems to your audio? Is it that clear? I mean, is it that bad or audio? Okay. Chest congestion. What else? You could have a productive cough. I think I already wrote it there. It's either productive or unproductive cough. All right. But it's most of the time it's a productive cough. Okay. You can have crackles. You can have crackles. You can have fatigue as well. You can have fatigue. Okay. Muscle weakness. You can have, of course, difficulty of breathing probably because of congestion. It's associated with your congestion. All right. Fever, of course. I'm just gonna emphasize on your fever apart from what I wrote here. The fever is 100.4, for example. I'm going to have a specific figures here, 100.4 or 38 degrees Celsius. This is Fahrenheit and this is Celsius. Okay, because that could be a sign of what? That could be a sign of SIRS. I mean, that could be a sign of sepsis. It's a spectrum, right? SIRS, sepsis, septic shock, and multi-organ. We don't want sepsis on this patient. All right, that's why you have to be very particular with your temperature as well. If the patient is not responding to antibiotics, and then your patient is not having defervescence, in other words, still having fever, so that's something else. It could be sepsis. Later on, I'm going to talk about complications. What else? Sweating. All right, sweating. If it's at nighttime, so that could be PTB. All right, not necessarily bacterial pneumonia. Okay, so what else? Crackles. Did I write crackles here? Right, crackles. Difficulty of breathing. It's there. If your patient, I'm going to emphasize on this one before I'll go with your complications. Okay, if your patient is suffering from chest pain, emphasis on chest pain. Okay, chest pain, chest pain, chest pain. If your patient is suffering from chest pain, this is an NCLEX favorite. That could be a sign of complication. So let's talk about complication. All right, the complication, one of the complication is what? One of the complication is pleural effusion. Okay, so pleural effusion. That's one of the complications, guys. Pleural effusion. If your patient is suffering from chest pain, the pleural effusion, guys, the chest pain, for you to at least rule out cardiac kind of chest pain or ischemic kind of chest pain, A chest pain related associated with your pleural effusion, it's usually pleuritic. When you say pleuritic, that is during inspiration. All right? You ask the patient when he breathes in, out. On inspiration, if there's a chest pain or a chest discomfort, that is pleuritic. It's not necessarily, ischemic. Okay? If the chest pain is, for example, even at rest, even if without doing anything, even position, nothing is relieved because of position, because anything else that you do or that you did, the patient is still having chest discomfort, that could be what? That could be ischemic kind of chest pain. But during inspiration, for example, that's pleuritic chest pain. That could be related to pneumonia, and that's a sign of a complication from pneumonia, which is pleural effusion. When you say like pleural effusion, effusion is something to do with the fluids creating too much pressure in your pleural cavity. All right? A cavity is like, the lining of your lungs. The lining of your lungs, there's like a cavity there between your visceral, part and the pleural part. I mean, the visceral and the outside part, the parietal part. Okay, so there's like a fluid there. If that fluid is already, it's not mobilized, all right? If it's not mobilized, that will create more pressure. That is basically your pleural effusion. That's why when you breathe, it causes chest pain during inspiration. All right. So what else are the symptoms of your pleural effusion? Don't forget, guys, if your patient is having chest pain, again, I'm going to emphasize on that. That could be a sign of your pleural effusion. That could be a sign. And there are some other, signs, symptoms related to your pleural effusion. And what are those things? Pleural friction rub. Okay. Your pleural friction rub. Your pleural friction rub. Your pleural friction rub is basically what? It's like a rock grinding to each other. It's like a rubbing rocks. I'm just gonna write it here. Rubbing rocks. All right? That's your pleural friction rub. What else are the other signs and symptoms? Unequal or asymmetrical lung expansion. Unequal lung expansion. Okay, unequal lung expansion. What else? What else? Tactile fremitus. All right, your tactile fremitus or simply your vibration. All right, tactile fremitus. Okay, so chest pain, pleuritic chest pain during inspiration. All right, CP is chest pain, please. CP is chest pain, pleuritic kind of chest pain during inspiration. Pleural friction rub, it's like rubbing rocks. All right, unequal lung expansion and tactile fremitus or positive vibration. Okay. Another complication, this is number one complication. Another complication is what? Another complication is ARDS, your acute respiratory distress syndrome, wherein your patient will have hypoxemia. And this is the NCLEX favorite, refractory hypoxemia. They will use the word refractory hypoxemia. So low oxygen in your blood. Okay? When you say refractory, that means to say what? When you say refractory, that means to say what? Refractory, whenever you give the highest form of oxygen supplementation, even the patient is already ventilated, but still the patient is desaturating. So that's refractory. In medicine, we call it refractory. Whatever the management is given to the patient, it's not working. Simple as that. ARDS is acute respiratory distress syndrome or also known as pulmonary edema. All right? Your pulmonary edema. In your pulmonary edema, this is a non-cardiogenic type. All right? You could have a pulmonary edema if your heart is not functioning well. All right? For example, like CHF. All right? Again, you can have pulmonary edema. A cardiogenic type of pulmonary edema is basically coming from a heart dysfunction. But if it's a non-cardiogenic type, it means to say there's something wrong specifically in your lungs, not necessarily in your heart. That's basically your ARDS. Again, another name of your ARDS, your acute respiratory distress syndrome, is non-cardiogenic type of pulmonary edema. You're building fluids there. All right? So what else are the other, signs and symptoms of your pulmonary edema? For example, like your pink frothy sputum. Okay, your pink frothy sputum. All right, a combination of, that's why it's frothy. A combination of blood at the same time air, which will make it more, frothy kind of sputum because because of this buildup of fluids in your lung interstitium. All right, that's your ARDS. But don't forget, guys, their favorite is refractory hypoxemia. If your patient is developing ARDS coming from pneumonia, the patient is refractory, refractory to any management, even if the patient is already ventilated, the highest form of oxygen supplementation, the patient is still having hypoxemia. And the patient could start having altered mental status because the brain is not getting enough oxygen. All right. One principle is that whenever your tissues in your body, any single cell in your body, whenever they don't get enough oxygen, they're gonna get wild. All right. Especially in your brain. Whenever your brain tissues or brain cells, your neurons will not get oxygen because that's what that's what we utilize for in making ATPs. That's the energy of the cell, di ba? Your ATPs, right? If you don't get oxygen and your glucose, and remember, guys, in your metabolism, 70% of your sugar is utilized by your brain. Remember that. That's why if you have hypo or hyperglycemia, brain, brain symptoms is always there because your axons and your dendrites as part of your neurons are very dependent to your sugar. Apart from that is your oxygen, talking about respiratory problems. All right? Because with your sugar and your oxygen as well, that is where they make ATPs. Your ATPs are the energy of the cell. All right? It cannot function if you don't have ATP. All right? So AMS is a sign of, actually it's an initial sign. It's a first sign of your hypoxemia if they are not getting enough oxygen. All right? Another thing is your septic shock. We don't want septic shock, guys. I would just say like sepsis. Okay? So sepsis, it's always like sepsis. Most of the patients, majority of the patients in ICU, in a critical care, and that's because of sepsis. And one of the reasons why we have sepsis because of pneumonia, apart from UTI, apart from liver abscess and many kinds of infectious conditions. And one of the one of the suspects there is pneumonia. All right, so you will expect, in relation to that, you will expect that the NCLEX will always ask about pneumonia because that's one of the major causes of sepsis. Because sepsis is the major condition in the critical care, all right, in the medical surgical field. So sepsis, okay, I would like you to remember this mnemonic, your curve 65. Okay, your curve 65. Look at the T here, that represents something. If your patient is having confusion, right, this is a mnemonic, guys. If your patient is having confusion or altered mental status, all right, so that's one sign of your sepsis. All right, because your patient is not getting enough oxygen. The circulating fluids in your body is having problems already. Sepsis will lead into septic shock. Remember that, right? Septic shock. You don't want septic shock because it's a circulatory problem. In other words, the circulating volume is not enough to sufficiently supply your tissues in your brain, your tissues in your liver, your tissues in your renal system, in your kidneys specifically. So that is basically a circulatory problem. All right. One of them is your septic shock. If your patient is having confusion, and that's something else. All right. Confusion, if you have uremia, for example, uremia is basically what? Elevated BAN and creatinine. Your kidneys are already failing. Your kidneys are already shutting down. How do you know? Elevated BAN and creatinine. And then, of course, if it's not functioning, take a look at your urine output. If it's less than 30 an hour, 30 ml an hour, that means to say that you have a developing renal failure. Okay? So uremia. Say like uremia, again, this is what? Elevated BUN and creatinine, or BUN and creatinine. and less than 30 ml of your urine output. Are you still listening to me, guys? Are you still listening? Are you still there? Okay, good. Thank you for coming today. Thank you for this wonderful audience that are still listening to me. Like, I know you will gain knowledge of, at least a little knowledge is, you cannot underestimate. Okay, because like I said, one is just too many for your NCLEX. You don't want to miss any knowledge, all right, to your NCLEX. You don't want to sleep there and then, okay, just watch Facebook or something like that. Please get up and study, study, study. This is a challenging kind of journey, guys, and I'm with you because I was also a one of you guys that working hard to achieve my dreams. Remember, if you don't work hard, if you will just think, okay, my dream will come true, these dreams will come true. If you don't want to work it out, definitely it's another good story. All right. What do I mean by that? Please make a plan. All right, make a plan. So create a plan in order for your dreams to come true. And I would like also to mention, guys, you can be inspired by my story. You can be inspired by anyone's famous people story, but please make your own story and be inspired more from your story. Kobe Bryant, he doesn't want to be Michael Jordan, right? He don't want to be Michael Jordan. Instead, he want to be Kobe Bryant. Of course, you know Kobe Bryant, right? Anyway, so please be inspired more from your own story. Don't be inspired by me. Don't be inspired by other, people, other famous people. For example, I'm not famous though. All right. So but again, please be inspired by your own story. Get motivated by your own story. And then you will see the next day, I'm a USRN already. Okay, going back to our lecture. Okay, this is letter R, which means respiration. Respiratory rates. The respiratory rate is more than 16. Okay, and letter B stands for what? Blood pressure. Are you listening, Miss Atara? Thank you for sharing your experiences and knowledge. I have a lot of experiences in my life. I don't want to share, my experience. You have a more, probably a more beautiful stories. But like I said, please be inspired to your own story. Okay? Back in the Philippines, I'm really, I'm just one of them that are really struggling hard. But guys, be inspired by your own story. Blood pressure is less than or equal to 90 systolic blood pressure. That means to say septic shock. All right. Oh, the patient's like 120s regularly. I mean, consistently 120s, 130s, 140s, for example, a little bit high, but it's still high. But the next time you got the blood pressure, it's 90 over 60. And the patient is having some mental status changes. That could be a sign of septic shock. So curve, what about 65? 65, this 65 is actually the age. All right, this is actually the age. They are the most commonly asked question in terms of risk factors. 65 and older people are high risk for developing, this pneumonia and other infectious conditions, okay, which will lead into septic shock. 65 years old, all right? And look up the letter T in the middle. That is basically temperature, all right? Temperature, elevated temperature, it's basically fever, right? It's basically fever. What's the good thing about NCLEX is that if you are using, I think the only country in the world that uses Fahrenheit is the US, and the only country in the world that uses miles, all right? Distance wise. All right. So, well, the good thing about NCLEX is that they're gonna give the conversion. They're not gonna tell you to convert the Fahrenheit to Celsius. All right. So 100.4 is basically 38 degrees Celsius. 100.4 degree Fahrenheit is 38 degrees Celsius. So don't forget, these are the three complications that you will expect in your NCLEX about, because this is how you prioritize cases. It may have complications, neural effusion, ARDS or ARDS, and sepsis as well, which will lead to septic shock and later on, it will cause damage to the organs, multi-organ dysfunction syndrome, or MODS. For example, the kidneys, even the heart, even the brain, those kinds of things. important organs in your body. Okay, and that's because you have a developing septic tract. These are organ dysfunction. Okay, these are the few complications, guys. These are the few complications. Let's take a look at the risk factors. Since I told you about 65, right? So the risk factors are what? Okay, the risk. This is also a favorite in the object, all right? Like I said, advanced age, 65 and older. 65 and older. What else? Who are those? Who are those people who are high risk in developing pneumonia? Audio is not clear again. Still, sir, audio. Okay, how about that? Unclear audio. So let me hold on. Is that clear now? Am I good now? Are we good? Hello, hello. I'm not gonna continue if the audio is not clear enough for you to understand my concepts here. I mean, my discussion. It's clear now. Okay. So more than 65 years old, and those people who are post-operative condition with post-operative condition. That's why another thing is that please encourage your patient to do incentives parameter. All right, incentives parameter. This is my savior when I had my COVID. All right, incentives parameter. Okay, from the word itself, incentive. If you do this incentives parameter, I mean this pyrometer, you will have some incentives. You will not develop lung collapse or atelectasis. This is very good for pneumonia, guys. And of course, we encourage early ambulation for a patient having, post-operative status. Okay, so what else? So post-operative patient, ventilated patients. All right, ventilated patients. Okay, ventilated patients. This is basically ventilator-associated pneumonia. It's also a favorite in your NCLEX. A pneumonia coming from a ventilated patients. All right, it's a hospital-acquired kind of pneumonia. It's a hospital kind of acquired kind of infection. All right, and patients who are with prolonged immobility, immobile patients. All right. So risk factors, these are the highest risk patients, 65-year-olds. Post-operative patients, please don't forget to encourage the patient to do the incentives parameter to prevent lung collapse, to prevent recurrent pneumonia. And ventilated patients, we don't want ventilator-associated pneumonia. And to those patients who are with prolonged mobility. All right, let's go to the management. Okay, any questions? Let's go to your management. Okay, let's go to your management. Okay, antibiotics. Don't forget, I discussed about the antibiotic ladder, and I hope you learned a lot from that antibiotic ladder. That's a very good kind of concepts or discussions in order for you to know which kind of antibiotics am I expecting to this these patients. For example, pneumonia. A mild pneumonia, for example, a mild pneumonia, which means ambulatory kind of pneumonia. All right, ambulatory kind of pneumonia. So since I talked about a little bit of microorganisms in your fungal, ambulatory kind of pneumonia, these are mild pneumonia, even with fever and cough, with fatigue, the patient can still walk. That's why they are called ambulatory pneumonia. In other words, it's almost like asymptomatic, so mild. Okay, give them, let's just say here, antibiotics. I'm discussing about antibiotics. Antibiotics of choice for ambulatory pneumonia are what? Azithromycin. Okay, I'm gonna make it yellow. Azithromycin. All right. This is a very good antibiotics for ambulatory pneumonia. Since ambulatory pneumonia, in other words, they can just give them azithromycin PO. All right, azithromycin PO. The microorganisms involved here are what? The microorganisms involved here are, for example, like Legionella. All right, who knows? They're gonna ask you about the microorganisms. Okay, what else? Legionella, and probably you can have also your mycoplasma. All right, and you could also have chlamydophilia. Chlamydophilia. All right. So Legionella, Mycoplasma, and Chlamydophilia. It's not chlamydia, right? It's Chlamydophilia. Legionella, Mycoplasma, and as well as Chlamydophilia. These are the common microorganisms or causative agents to your ambulatory pneumonia. In other words, the patient is asymptomatic. It's almost asymptomatic. They have fever, low-grade fever, cough, and other signs and symptoms. They can walk. Give them azithromycin. These are outpatient, outpatient status. Let's move on to your moderate, in terms of symptoms, moderate symptoms. This is basically your community-acquired pneumonia, all right? Community-acquired pneumonia, probably because of, for example, the most common, which is your strep, or streptococcal kind of microorganisms, or probably because of your Staph aureus. All right. But let's just say methicillin sensitive Staph aureus. Okay, they are sensitive to, they are responding to, for example, napsilin. All right. For example, napsilin. I discussed it already to you guys. Last month, right? Strep, Staphylococcus aureus. These are the most common types, more microorganisms related to your community-acquired pneumonia. Okay, they can have moderate symptoms. All right, the patient can get, for example, I'm going to make it in yellow. They can also get azithromycin. All right, it could be IV. They can be admitted because they have moderate signs. Clinically they're not okay, but they are not really toxic. They are not really, like, sick. All right, they can get IV or PO azithromycin as well, and you can also combine it with other medications, right? For example, like ceftriaxone, or brand name Rosefin, azithromycin, or ceftriaxone. Ceftriaxone is, since they're admitted, it's only in a form of IV. All right, it's only in a form of IV. Or if you want, PO medication, you can have moxifloxacin. If you notice, these are broad kind of antibiotics, which means to say it covers, gram positive and gram negative. Streptococcal is gram positive. Staphylococcus aureus is also gram positive. And who knows? It's a different kind of microorganism. So might as well ceftriaxone and moxifloxacin, which are broad spectrum or empiric. It covers both gram positive and gram negative as well. The same thing as with azithromycin. The good thing about moxifloxacin is that it's either you can give it IV or PO. All right. Can you also give Levaquin? Yes. Levaquin is your levofloxacin. In your NCLEX, guys, 99% they're gonna give you generic name. So levofloxacin. A levofloxacin is also a blood spectrum kind of fluoroquinolone. It's not your methotrexate. The good thing also about levofloxacin is either IV or PO. I think I'm extending again. Give me like 2 minutes to discuss this. We're almost done here. So antibiotics for mild, azithromycin. For moderate, which is for community acquired pneumonia, against azithromycin, plus ceftriaxone, IV4, or either moxifloxacin, or you could also anticipate the preference to be levofloxacin. Okay? In the form of IV, or the patient goes home with PO medication, PO levofloxacin, and not acquired with azithromycin. It's very convenient. Right? It comes with the heat up, we call it the heat up, right? So this is day one, this is day two, day three, day four, day five, right? It's something like that. Let's go to your severe form. Okay, let's go to your severe form. My audio is still, oh my goodness, my audio is not really good. I don't know, for some reason. Again, the audio. Okay, hold on. Let me stop my sharing, and then let me go back to, hold on. How about that? Can you hear me? Can you hear me, guys? Am I good? Can you comment? Hello. Are we good? You're clicking the thumbs up button. I guess we're good. Yes, it's clear. Okay, I don't know for some reason. Okay, let's go to severe kind of pneumonia. The patient is sick as I don't want to say the word. These are patients with ventilator associated pneumonia. Hospital acquired pneumonia, ventilator associated pneumonia, and you see them because I said like they are sick. You see them in the ICU. You see them in the critical care. Okay, severe form, of course, we wanted to give some higher form of antibiotics. All right. Who knows it's already MRSA, right? Who knows it's already MRSA? This time it's not sensitive to methicillin anymore. This time it's methicillin resistant Staphylococcus aureus. MRSA, it can be everywhere. It can be in your sputum, it could be in your blood, bacteremia. It could be elsewhere. It could be also in your urine. That's why it's very important to get the culture before you start the antibiotics. Again, it's very important for you to start the culture before you start the antibiotics. Okay? Because it's gonna be useless if you already started your antibiotics and then get your culture. Get your culture first before starting the antibiotics. Those are simple instructions that you need to know, and they're gonna ask you about that in your NCLEX. Okay? Sometimes in a passive way, in a tricky way. That's what I'm talking about. So MRSA, it could be many forms of microorganisms. It could be ESBL. It could be Pseudomonas, right? It could be Pseudomonas. I discussed that already, guys, last week. This is severe form of signs and symptoms. Okay, hospital acquired pneumonia. Okay, you expect that you will give higher forms of antibiotics, for example, like vancomycin. All right, because you're thinking about MRSA, that's the drug of choice or antibiotic of choice for MRSA. Vancomycin, you can add piperacillin plus tazobactam because this is good for Pseudomonas. Because, like I said, who knows what kind of microorganism is this? Vancomycin plus piptazo or Sozin, the brand name. Okay, like I said, the NCLEX is always asking you about 99% generic name. So I'll go with the generic name. Vancomycin and piptazo as well. All right, so vancomycin and piptazo. If you want to add up some higher form of antibiotics, for example, like uh, linezolid. Oh, it's already on your culture. It's already vancomycin resistance. Vancomycin resistant kind of enterococcus. It's a gram-positive kind of microorganism. So you can add up linezolid, for example, which is the highest form of your antibiotics, which covers gram-positive as well, and some forms of gram-negative. Well, that's vancomycin. This is most commonly given, and as well as your piperacillin and your tazocin. Let's go to your management. Okay, approach to your management. All right, I'll share my screen. I'm sorry. Haven't shared my screen yet. Hold on. Share screen. There you go. Okay, so severe hospital-acquired pneumonia. I'm talking about ventilator-associated pneumonia. Vancomycin plus piperacillin tazobactam because it covers, it's very good for your Pseudomonas and some other microorganisms. Okay, and vancomycin specifically for MRSA. But again, if your patient is having resistance to these microorganisms, to these antibiotics, for example, vancomycin, go with a higher form, which is linezolid. Okay, let's go to your approach to your management. Okay, management approach. So management, I discussed about antibiotic wise. Let's discuss a little bit of the nursing approach to this. Okay, the nursing approach. The length of stay, LOS means length of stay. You wanted to discharge the patient. You were anticipating discharge. As soon as possible, you will do your discharge planning because you want this patient to discharge as early as 3 days. Okay, as early as 3 days. Not unless if your patient is developing, ventilator-associated pneumonia. Of course, they're gonna stay there longer. All right. Of course, we don't want this patient to stay in the hospital because they can acquire a different kind of microorganism, well, it will just recur and recur and recur. It's gonna get, more critical to the patient. Okay? So length of stay is 3 days. All right? Length of stay is 3 days. Ambulate. All right? Ambulation is very important. Ambulation is very important. Fluids. Question is, how much fluids are you going to expect to your patient? Okay? 2 to 3 liters. 2 to 3 liters of fluids in 24 hours or per day. Okay? So the diet management. The diet management is, of course, high caloric diet. All right? Remember, your patient is having inflammatory kind of conditions, infectious kind of condition, high caloric diet. It's very important for you to check for fever. All right? It's very important for you to check for fever of your patient. If the fever is still positive or is still present, you have to do re-imaging after 3 days, and then your patient is already getting antibiotics and so on, blah blah. So much, management you've given to your patient. You're already maxed out. The patient is still having fever. Okay, the patient is still having fever, so you have to expect that the doctor will order re-imaging using the CT scan, using the CAT scan, because who knows, this is already empyema. There's already pus in the lungs, all right? And as well as your pleural effusion. If the pleural effusion is large enough, you expect that the doctor will order thoracentesis. Okay, that's the management of choice for pleural effusion if it's large. Okay, thoracentesis, and who knows, this is already malignancy. This is already cancer. All right, so cancer. Again, if the patient's fever is not subsiding, expect the doctor to order CAT scan. You wanted to know, or they wanted to know, that if there is empyema, a massive pleural effusion that needs to have thoracentesis, and as well as cancer, which is pretty common here. Let's go back to your management. Apart from your ambulation, fluids, diet, which is high caloric diet, don't forget half coughing. I would like to emphasize on this one. Half coughing. Have you heard about this? All right. Half coughing. Half cupping is very good. All right. Half cupping is really very good because it will mobilize secretions. It will mobilize your secretion. So decreases secretions. It will also eliminate your CO2 because along the process you also do your first slip breathing. So decreases your CO2 by doing the first slip breathing. Okay. At the same time, prevent atelectasis, prevent lung collapse. You do it. Not nothing from the word of top. Something like that. Alright? You are mobilizing your situation. You're mobilizing your situation along the way, along the process. You also do your first with respiration. Okay, first with breathing. Okay? When you are first with breathing, you are prolonging your expiration. If you are prolonging your expiration, you are also eliminating excessive amounts of CO2 in your breathing. And by practicing lots of not practice, you are also preventing cases. Just like your incentives parameter. Okay, just like your incentives parameter. Okay, so the half cupping as well. You expect that you have chest physiotherapy, and pain medicine. Pain medicine, guys. You don't want to talk. You don't want to talk because you can suppress the talking center in your brain. It's up directly to your brain, right? So you don't want it. You don't want it because it suppresses itself. Anything that says dextromethorphan in your genetic code, you don't want it. What the person is okay, diaphragm is okay, you can stop them, right? Diaphragm is okay, you can stop them. Third, the system is okay because it's a new policy. You want to expectorate with your diaphragm, and you wanted to restore the situation by using
They have reputation. Reputation. Some kinds of reputation with dextromethorphan. As I said, because reputation is a brand name. And some reputation as well doesn't have any dextromethorphan, but most of the time
There is dextromethorphan. All right. If you see that Robitussin in the over-the-counter, if you go to the pharmacy, if you see that Robitussin has a dextromethorphan, it's not good because it suppresses your cough, especially if you're having bacterial pneumonia. You wanted to expectorate only. You wanted to dissolve the secretions, not to suppress the cough. All right. So any medications that has dextromethorphan on it, please don't give it. And pain medication that has, I mean, of course, narcotics. Pain medication of course, narcotic medications can also suppress your cough. You don't want it because you wanted to expectorate the secretions. Okay? You wanted the patient to cough it out. Okay? Pain medicine. And they're also gonna ask you about the positioning. All right? What is the positioning of your patient, by the way? Again, the audio is not clear. I don't know. We're almost done anyway. So, positioning. You position the good lung down. All right? The good lung down. Okay? Position. This is the first time that I'm having problems with audio on my lecture. I don't have any problems with my audio. This is the very first time, having problems in audio in my lecture in IPAS. I'm talking about the IPAS. Good lung down. Position your patient on the side wherein the good lung is down. Okay? That is for unilateral pneumonia. Okay, for unilateral pneumonia. If your patient is with bilateral pneumonia, which means to say two lungs, okay, so best position is high Fowler's position. Okay, best position is high Fowler's position. Did you understand? Okay, so these are the common, management that you will expect that they're gonna ask you about. Very important to instruct the patient to ambulate. Fluid management, diet, which is high caloric diet. Half coughing is becoming, famous nowadays in your NCLEX. Just physiotherapy, pain medicine, but not the narcotic type. Positioning of your patient, the good lung down. This is to promote circulation as well. Okay, to promote circulation. Good lung down if you have unilateral kind of your pneumonia. Okay, so I guess this is the topic for today. Okay, it's very important for your discharge teaching as well that please follow up your doctor after probably about a week because you wanted to have a repeat chest X-ray. Very important for you to report fever because that's recurrency. All right, and very important to finish the antibiotic.
but for sure, after you get discharged, you will get, fewer antibiotics. Finish the antibiotics, otherwise you will develop antibiotic resistance. Okay? And also, please, for those who are high-risk individuals, all right, pneumonia vaccine every 5 years. High-risk individuals, like for example, like elderly, 65 years old and above, or for example, if you have autoimmune disorders, all right, if you have some immune conditions, please, pneumococcal vaccine every 5 years. This is a high risk. Again, don't forget antibiotics will be completed. Please don't stop the antibiotics abruptly. Complete the regimen. Complete the therapy. For example, if you're given like 7 days, complete it in 7 days. Otherwise, you will develop resistance. Okay? So thank you for today. And I would like to, I'm not a bias today. For those who are, the
Retakers. I'm talking about retakers. Uh, don't lose hope. Right? I know you guys, you've been taking it for probably like the second time or third time or fourth time, the fifth time. Don't stop. Because obviously when you stop and then the dream, and your dream is already gone. Okay? Because you already stopped. Again, I'm gonna be biased to those who are retakers. Sometimes uh uh bias in a sense because I'm also particular with those who are taking it the first time, huh? Okay, but I'm telling you, I'm telling you, retakers, especially retakers, uh, I pay particular attention, more attention to the retakers because I know they're really struggling a lot because they wanted to really get it. But sometimes, uh, being rejected because you feel like you're rejected, right? You feel like you're really rejected. Sometimes rejection is a form of God's redirection. You know what I mean? Like again, sometimes in our lives, rejection is a form of redirecting us. And I'm talking about God's redirection, you know, but we have the same goal, all right? He might redirect you in a different route, but we have the same goal. Just wait until you get your exam, all right? Just wait until you get your success. Redirecting in a sense that I might be poor on this, I might be poor on that. I need to change my strategy. I need to at least relieve my anxiety in dealing with this exam, because anxiety is one of the most reasons why you are unsuccessful in your exam. You are not able to overcome the anxiety. That's why in IPAS we have some mentors. They don't do the lectures, but they only do the mentoring to at least relieve your anxiety before you take your examination, because that's one of the reasons why you fail your exam. And I hate to say it, I hate to see people who are failing. We don't want failure. Just believe in yourself. Like I said, for those who are retakers, guys, for those who are first time takers, I know you can make it. Don't think about the next time around that, okay, if I'm going to fail, what I'm going to do, those kinds of things. Those are negativities. Please think that you are going to be able to make it on your first try. For those who are retakers, again, like I said, don't lose hope. Don't feel like you're rejected, because rejection sometimes, that's God's way of redirecting you on a different strategy, on a different route with the same goal. The moment that you stop, again, your dreams will be shattered already. It will not come true. It's just another story, like I'm telling you guys. And well, sometimes we are so, uh, I would say like uh, some people say that success is not permanent. For me, on my opinion, success is permanent. Sacrifice is temporary. If you feel like really tired, think about your motivation, and you will be motivated again. Think about your inspiration. You will be motivated again to, okay, do my thing. Study, study, and study. This is challenging, but I can make it. Sometimes you feel tired. You can do some uh, activities like to at least freshen up and then start it again. Okay. So have a good day, everyone. God bless everyone. The Christmas is approaching. Merry Christmas, everyone. And like I told you, the first thing, on my lecture, I was seeing the bright lights. That's the very meaning of Christmas. To see the beauty of Jesus Christ. Like, you don't deserve your salvation. You don't deserve your this grace, but that's grace. That's God's grace. You know, you will deserve that success, and that is the topic for today. Okay, so thank you, and see you next time. And in my to my students in IPAS, see you tomorrow. I guess I have a lecture tomorrow for cardiology. All right. So thank you, and have a good day, everyone.